Good day and good afternoon to all our friends around the world. My name is Kay, and I welcome you to the 9th live interview by the On Foundation. Today, you can look forward to a highlight. We've got two giants in orthoregeneration, both on the side of research as well in clinics. Both of them also have led the creation of this foundation less than 3 years ago. They are so famous that they actually don't need much of an introduction. Nevertheless, I want to do it quickly because so far it's only two of us in the studio and we're waiting for the third one. Today, I will hand over the moderation of that live interview. This will be done by Professor Myron Spector, who's already sitting with us. He's doing biomaterials research since 50 years, and he's running a tissue engineering lab in Boston. And he has professorships by the Harvard Medical School and at the Brigham and Women's Hospital. And he's also teaching at MIT. So he's quite active. He will be interviewing today, and he will interview nobody less than Dr. Brian Cole. Brian Cole is probably the best known sports medical surgeon in the world. And he's also active in research, and currently he's president of the On Foundation. He's a professor for orthopedics, anatomy, and cell biology at the Rush University in Chicago. And he's also managing partner at the Midwest Orthopedics at Rush. So currently we are still waiting for him, so I can add information that he's also the team physician of the Chicago Bulls and the Chicago White Sox. So there's a lot he can talk about as soon as he joins the studio. While we are still waiting, I want to welcome everybody out there on YouTube and Facebook. And as usual, please introduce yourself. If you haven't done it already, tell your name, tell your city where you're watching us. And now, I don't let you wait any longer. Well, actually, I will let you wait for Brian, but I'd like to welcome Myron. Myron, the home studio is yours.
Thanks very much, Kay, and welcome to all of you who've been able to join us in this interview, which is one of a series of interviews that the On Foundation has put on, and you can find the links to them on the On Foundation website. You know, it's a particular pleasure for me as a PhD biomaterials researcher to interview a surgeon who is a leader not only in seeing patients and performing surgery, but also in leading research efforts to better demonstrate how biomaterials, medical devices can help patients in the future. You know, none of our biomaterials can be fashioned into a medical device and actually be used in the clinic without the orthopedic surgeons like Brian Cole, and I have a feeling many of you out there as well. So as a PhD, as I say, it's a pleasure to be able to interview and ask some of my questions that I have to our orthopedic surgeon colleagues. I think too, as Kai said, Brian represents an outstanding model for young orthopedic surgeons who might aspire to an academic orthopedic career. When you read his CV, you might even become exhausted at the amount of work that he's been able to achieve. And what's of importance is not only seeing patients and performing the surgery, but in doing administrative work, teaching, mentoring fellows and young orthopedic surgeons, and then actually doing the research itself. So these are varied activities, and Brian has excelled in all of them. And in that regard, it's important, I think, for all of us to see what lessons we can take away when we hear from Brian, what his aspirations were when he was young surgeon starting out, and who he looked to for guidance, who were his mentors as well. One of the other of exceedingly important activities that Brian has gotten into, has been involved in research, is the engaging in clinical trials of his work. So Brian, welcome. Good to see you. Good to see you. We've given you a very nice and deserved introduction.
Can you do it again? I missed the first 30 minutes of that.
No, I think you're so modest. You're so modest that I would have never imagined you becoming too much of a swelled head, as we might say, if you hear everything good we've said about you. But you know, Brian, I was just saying, Brian, that when one reads your CV, one could not help but be impressed but inspired by everything you've accomplished. And what I was just telling those listening in was to know what led you. When did you first imagine you would want a career in academic orthopedics?
Well, I won't bore you with the details, but if I told you how I got to where I am, you would probably be incredibly surprised. When I decided to go into medicine, I used to. Do you remember the Bob Newhart show?
Yes, yeah, I do.
I used to think I wanted to be Bob Newhart. Okay, so I actually went to college thinking I wanted to do child psychiatry, believe it or not. And then when I went to medical school, I was deciding between, the challenge was I just didn't find a niche there at all that was really, it was something I thought it wasn't in the end, and was between OB-GYN, infertility, and then orthopedics as a latecomer. So I was actually very late to orthopedics. It's interesting, when you talk to students now, most of them go into orthopedics, they're born to go into orthopedics. You know, they're born, and then at the age of 1, they tear their ACL. At the age of 5, they dislocate their shoulder, and then from that point forward, they want to go into orthopedics. And that wasn't my progeny moving forward. It was a very late decision, but it was largely based upon the fact that the greatest thing about orthopedics and musculoskeletal medicine is that there's a huge nexus between seeing or identifying a problem in the office setting and asking a question and then solving it and bringing it back to the clinic. And you can do that in short order. So while there's a lot of molecular and in vitro work, but you can quickly ask questions and solve them and then directly bring them back to the clinic. And if you look at my CV, most of my research is really in that area, saying, look, let's ask a really simple question so that when you're in the office, you can actually speak with the patient and help them help to understand what their expectations are and then determine the probability that you're going to meet their expectations. Mm-hmm. And to me, that's one of the greatest things about orthopedics, and that's why I gravitated towards academic medicine.
Mm-hmm. And Brian, tell me, were there more senior faculty that sort of served to guide you or served as mentors, or who you wanted to model your own career after?
Myron, it's a good question. When I mentor younger people, I often say that those who you follow and who mentor you are sort of like life's smorgasbord. You sort of identify individuals. You don't certainly have to aspire to emulate all of their characteristics and personality traits and motivations, but you can sort of pick and choose. And when we train fellows, for example, they rotate with 5 to 7 individual attending, say, in the division of sports medicine. And I always tell, I said, look, you're going to learn 5 to 7 different ways to do it. You're going to see different ways to evaluate patients and sort of pick and choose from the people who have really inspired you most. So when I think to the people who have really had huge impacts on my life, it has been people like Joe Lane from the Hospital for Special Surgery. I was honestly very familiar because he's in biomaterials and biochemistry and cartilage biology. Was very inspired by actually some of the work that you were doing, even when I was a resident. Russ Warren, who is still to date always a student. Freddie Fu, Bernie Bach, one of my senior partners. Each of them have some really amazingly strong characteristics as human beings and academicians, and just the way they manage and think about people, that I sort of have always picked and choose to say, this makes sense. I really really can understand the way they process and deliver, and have done that along the way. So it isn't any singular person, but I'm blessed to say that I have at least a dozen people in my life that have had huge impacts on the way and who I am today, including my parents.
Very good. And tell me, you underwent your training at a time when joint replacement reigned, right? Using metals and plastic to replace joints. These were very strong, influential leaders in the field. And what led you to see the potential for regenerating tissues, for biological solutions rather than simple replacement?
Ironically, my first publication in a peer-reviewed journal was a study that utilized implants in canine femurs coated with hydroxyapatite with and without BMP. That was my first real basic science study that I ever did. And that was under the supervision of Joe Lane. And in my residency at the Hospital for Special Surgery, after I took a year of research in ortho in biologics and cartilage biology, I saw a litany of patients coming in, especially through sports medicine, where they would undergo simple arthroscopy. And I specifically remember a case where early in my residency, when we being taught how to do arthroscopy, where it was a woman in her early 20s who had a cartilage defect of her patella, really common entity. And we were doing an arthroscopy, and I remember turning, it was Tom Wickowitz, who has also been a tremendous role model. I said, I was like, Dr. Wickowitz, is this really going to help this woman? He's like, we're just going to shave away the little crab meat appearing cartilage. He says, yeah, hopefully for the time being, it'll buy her some relief. But when her symptoms come back, she's going to be out of options. And in the 1990s, the only option available was debridement and marrow stimulation. And didn't even have a good understanding of how we can make marrow stimulation work at the time. And there was almost nothing available. And certainly the only injectable we had to modify symptoms was corticosteroids or depo-steroids. And that was it. And when I finished my residency, I recognized that there was an enormous white space and paucity of solutions. And we started thinking really hard, thinking at odd times of the day, not necessarily seeing patients, but in the middle of the night, waking up, thinking about these problems while running, while exercising, just pondering how we really have no treatment algorithm for these people. And there are literally tens, if not hundreds of thousands of people who have no solutions, who are otherwise perfectly healthy, which is one of the great things about orthopedics. We're dealing with otherwise very healthy people, but these were individuals who had no solutions. And I will tell you that that's what really prompted me to become very interested. And when I finished my fellowship at the University of Pittsburgh, we had, it was just the time when it was ACI had gone through the FDA. It was 1994 when the first Peterson paper was published, and Dan Grandy, that looked at the results of ACI and showing that of the femoral condyle we can do well, the patella not so well with that first series. And then octagonal autograft transplantation in 97 with just simple instrumentation to core out a cylinder of bone and cartilage and take it from a healthy area and take it to a damaged area. And that was it. That's all we had. And fast forward, it's ironic that nearly 25 years or more later, we don't have a lot of additional options in the area of biologics. It's actually somewhat sad in a way, but we certainly have identified in the orthobiologic space, which has become increasingly interesting, non-surgical ways to at least modify symptoms. The challenge is clinical utility or utilization has exceeded or outpaced our ability to study it with true evidence-based medicine, although we've gotten a whole lot better over the last 3 years.
No, that's great. And listen, speaking about evidence-based medicine, you've participated and led many clinical trials of procedures and devices, approaches in the clinic. And this raises the questions about, interest about the many challenges in performing clinical trials, selection of control groups, for example, the metrics used for outcome. So I'm just curious, and from your point of view, when one thinks about the kinds of experiences one draws from clinical trials, what do you see yourself as potential shortcomings and how they're performed and how they might be improved?
Yeah, I mean, I think that's a terrific question, because one of the biggest challenges we have is first, the burden of a clinical trial is in some ways welcomed. I mean, the role of the FDA, excuse me, is safety, and then secondarily efficacy, and it protects the public. And we've even seen issues today with the pandemic, for example, when shortcuts are provided for example, testing, antibody testing or PCR testing, it introduces problems. And the FDA basically its pure intent is to provide protection and to make sure that we're doing things properly in a clinical study. The challenge is when we do things properly to really isolate the important independent variables leading to a dependent variable of a positive outcome, it creates a population to be studied that is not representative of what really walks in the office. So, for example, most of our clinical trials in the area of cartilage research have stalled because for two reasons. One, because placebo studies are challenging, and placebo has a positive impact. Once you go through patient selection and choosing patients that are proper for a study, they are study ready, and placebo can have a tremendous positive impact. And we've seen that in our studies of HA, PRP, any injection trial, we've had a significant impact of placebo. Even if you go to the literature level 1 and 2, the effects of placebo, you see results that are 35 to 45% of patients meet some meaningful clinically important difference. And they got basically, for all intents and purposes, nothing that's biologically active. So beyond the problem of placebo is the fact that these often, when you go to surgical trials, very difficult to find patients who are willing and stay equipoised. In other words, say, look, I know there's other options out there. How am I overtly going to ignore going for those other options for the sake of being randomized to an investigational solution when they already may have a solution out there? And we don't know if that investigational solution is any better than what's readily available. And then finally, the biggest challenge is the fact that when you look at the population that ends up getting studied, as I alluded to, they don't represent what walks in the office. So to find a patient who has an isolated cartilage defect, for example, who has not had a previous treatment, whose BMI is less than 30, who's not malaligned, hasn't had a meniscectomy, who is between the ages of 18 and 60, that's a unicorn. That's not something that walks in the office every day. In fact, it walks in maybe once a month in a mature cartilage practice. So the biggest challenge that we have is, as I summarize, is the placebo aspect, the fact that patients and sometimes clinicians are not equipoised in terms of presenting a clinical trial option to a patient. And then finally, the population isn't representative of what actually lives in the real world. So progress can and will be made by modifying, not compromising safety assessment, but modifying how we do clinical trials so that we can make it more representative of the real world so we can actually get them done. There's been at least 3 or 4 clinical trials that have been aborted in the middle of the phase 3 trial, not because they were having problems with technology. Technology is actually working extremely well because we couldn't fully enroll these patients in this clinical trial.
Mm-hmm, mm-hmm. Well, you mentioned too. This brings up some of the specific challenges and problems that patients have in our musculoskeletal tissues, including the cartilages in particular, articular cartilage, meniscus, the intervertebral disc. I mean, these are simple tissues insofar as they have basically 1 or 2 cell types. Often no vascularity, no nerves, and yet they are so difficult to regenerate. So I'm wondering what you see as approaches that might be used to finally be able to come close, at least, to regeneration of articular cartilage or meniscus or the disc. What are your thoughts on that?
Yeah, so there's some conceptual things that we've learned from our failures over the last 5 years. And the first is that the articular cartilage doesn't tell the whole story. We've really learned to understand the joint, and if we just use a knee as a model, as an entire organ. And it starts with pain and our futile understanding of why people hurt and why some people don't hurt. And that's the first challenge we have. The second challenge is understanding the natural history, who does poorly, who progress, and who does not. So when you tie those two things together, it becomes incredibly complicated. We've also learned that it's not just about loss of cartilage, it's the secondary phenomenon that happens with changes in the bone, changes in the lining of the joint, proteins that are produced. So when you think about how complex the patient profile is, we start to learn that we actually can intervene in a variety of places. we've often spoken about how the holy grail is to regenerate cartilage. And I still believe that is the holy grail, but it's not the only holy grail. I think we have to have a very fine understanding of why people hurt. We can intervene in pain pathways, even absent of regeneration. We have to have a better understanding of where load factors in. We've learned, for example, that malalignment, the people having bow-leggedness or knock-kneedness or increasing their BMI, you can take an asymptomatic patient and they become symptomatic. Flip side is they can lose weight and they can become asymptomatic and still live with the same disease. And then the final issue is, how can we regenerate cartilage to prevent these secondary phenomenon from even becoming relevant? And you're right, it's relatively acellular. It has a paucity cells, has almost very little blood supply, but does have some. And we have learned over time that cell-based technology, potentially augmented with biologics and the scaffold, are probably the things that are going to solve a lot of the problems that we have in the future. So specifically, it's not just about the cells. It's not just about the growth factors. It's also providing conductive, or what we call scaffolds, which I know is an enormous body of research in your life's and much of your life's work. It all now is becoming relevant and coming full circle, that we probably have to stop parsing it down into individual parts and start thinking about how we can combine these things collectively to get the best outcome for our patients. And we should also think about the paradigm that we may not actually need to regenerate some things to get a good outcome. So we have to really think outside the box, given the challenges we've had. Truth be told, we can regenerate cartilage now through cell-based technology. We can regenerate imperfect forms of cartilage through procedures that harness the body's ability and willingness to heal through their endogenous or normally housed MSCs, cells that are not only little pharmacies, but can actually be driven to do very specific things that might reduce inflammation and so forth, and even modify the immune system. And so we're learning a whole lot. And I'd say, if you ask me how we are today, I would say we're about, we get triples. In other words, when I was a resident, we didn't even get to first base. Now we can get triples. We have a 75% rate with properly applying the various things we have available. But when you talk to your joint replacement colleagues, metal and plastic, they're still upwards of 80, 85%. They're not 100%. So we want to squeeze out that extra 15, 20% to do better for our patients.
Mm-hmm. You know, and as you talk about the orthobiologics, what I think is very encouraging are the tools that we are finding that we have available in the operating room itself, like platelet-rich plasma, like bone marrow aspirate concentrate, that you as an orthopedic surgeon can prepare, fashion yourself right in using your patient's tissues. So that's encouraging. On the other hand, and it's being used in a widespread fashion for a wide variety of orthopedic and, of course, other surgical applications. But of course, right now, the preparation involves diverse procedures and even equipment, centrifuge, for example. So the question is, to what extent do you think there's now finally, I would say, a need for standardization of the preparation methodology and devices used for PRP and BMAC?
Yeah, it's an important issue, because initially we would say, well, there's PRP, and 10 years ago we would say, well, just the more platelets, the better. And then we find out that platelets don't tell the whole story. They're just one part of the story. And like many things in orthobiologics, we have these bimodal distributions where more is not better. In fact, more can actually be harmful or inhibitory. So we've learned that more is not better. And then we've also dug a little bit deeper to say, what are the things that are sort of active and imposing change, and how are we doing it? So with PRP as that model, what we've learned is we can't, especially if we're going to study it and decide that it actually has an effect or does not have an effect, we have a responsibility for what we call biorepositories. So what we're doing now is we focused a lot on clinical outcomes, but we traditionally have done a very poor job of lumping things together in terms of the independent variables of the things we just pile in and say, oh yeah, this is how we get a result. We're now becoming much more critical about how we perform clinical studies and treat our patients. So for example, with PRP, we will typically take an aliquot, and we're not just looking at the fold increase in platelets. We're actually looking at the white count, the distribution of that white count, the hematocrit, or the amount of red cells, for example. And characterizing PRP and classifying it in that way has become really, I would say, the gold standard for research, so that we can say, look, maybe for a disc, this type of PRP can be used. So we were sort of customizing to pathology, and maybe for the rotator cuff, we should use this type of PRP and at the time of repair. And then maybe for patella tendonitis or Achilles tendonitis or heel spurs or plantar fasciitis, we should use this type of PRP. And we've become much more astute, but the only way it happens is if we really focus on this concept of a biorepository. So the ability to deliver is not, doesn't tell the whole story. We have a much bigger responsibility on our hands to continue to characterize what we're delivering to our patients.
No, and as we talk about delivering biologic-based solutions to patients, we have a number of people logged on who are sending their greetings to you, and in this current atmosphere, right, of virus and immune systems, Tiago Fernandez, who's logged on from Brazil, he asks, so what about the immune modulation of patients, and perhaps even the use of synovial macrophages, as an option, a therapeutic option for orthopedic patients in the future?
So immune modulation is an enormous recognized factor when it comes to the use of, say, MSCs in general. We are less focused today on the use of MSCs to be terminally differentiated than we are on actually modulating the immune system and how our bodies actually respond to disease. And that does actually intrinsically relate to the synovium. We've become much more aware that the synovium is part of that interplay, part of the organ, as I've alluded to, and the synovium and the lining these cells and what's produced by them have a dramatic effect on how we feel, for example, in an arthritic situation, and also in our ability to heal or not heal. So much of our research, for example, at Rush with Adam Yankee and others, and Susan Chubinskaya and some of our other biologists, is actually focusing on the role the synovium has. Specifically with macrophages, to date, we haven't specifically looked at it, but arguably it's relevant. If you think about how joints get destroyed in patients who are hemophiliacs, and our concerns that the hemarthrosis, for example, at the time of ACL tears, is actually a relevant, potentially degradative process, you start thinking about where do these cells come from, and macrophages inevitably may play a role, especially when it's combined with inflammation. So you're asking the right question, and I wish I could answer it more intelligently in terms of a solution we have today. But what you're alluding to, I think, is that we're not just focusing on articular cartilage loss anymore. If we're going to use, for example, orthobiologics, we've got to understand not only how it affects a chondrocyte, for example, but how does it affect the bone, the subchondral bone, the local or host MSC's response, the immunologic response by that patient, the synovium, the synovial fluid, and also even peripheral serum factors. So that's what I was alluding to before. I said one of the great things about orthopedics is that it just never gets boring. And every time we start to scratch the surface, we get, there's the magnitude of questions, the fold increase in questions is absolutely exponential that we need to answer. So there's still plenty of work to be done in this area.
Very good. Let's turn our attention, if we can as well now, to rehabilitation after these biologic-based procedures, and trying to improve repair, regenerate tissues. And compared, let's say, to joint replacement, actually the timeline, of course, is much different, often quite a longer period of rehabilitation for patients undergoing these cartilage repair procedures. And it is a challenge. I mean, speaking personally, as well as an individual who needed a lot of kinds of musculoskeletal repair procedures, thinking that one would restrict your activities for months before really knowing the degree to which there would be some benefit. What do you see as the potential reduction in the timelines for rehabilitation in the future?
Another great question. The insult of surgery is sometimes worse than the disease we're treating. And that's because we're always trying to fight that balance between protection and the benefits of protection versus the benefits of stress or the disadvantages of stress. A lot of the things that we do take time to heal and regenerate or just deliver an end product that can satisfactorily respond properly to stress without breaking down. And it's a fascinating area. And so much of our rehab principles are predicated on timelines that are broken down in phases. For example, 0 to 8 weeks, 8 weeks and beyond, and so forth. But that doesn't hold true for every technology that we utilize. So, for example, arguably for marrow stimulation is a procedure where we intentionally violate the bone with small holes, and we are asking for the patient's own endogenous MSCs to come into the area to form a scar of cartilage. It's not perfect, but it can often serve as second best. Cartilage can respond responsibly to load, but if we load that immediately after it's done, then the bone sees load and can actually respond with fracture repair. So while we're trying to develop a healthy surface, if we overload it too soon, we get fracture response, bone spurs, literally, or osteophytes, collections of bone in the center of these defects, because we've loaded too early, because that's what happens when you load a fracture. They form callus, they lay down calcium and form bone. So we are constantly battling this balance between too much and too little. And every technology brings different things to the table. If you put in an osteochondral allograft, which is a donor plug of bone and cartilage, I would tell you that by 4 to 6 months, it's pretty stable, but we worry about the bone breaking down. So what do? We're now soaking that graft in bone marrow concentrate and studying it over time to say, look, if we get serial CAT scans to look at the bony integration, maybe we can return a patient back to sports sooner if we can get the bone integrate. The cartilage does a fine job with a donor graft. If someone donates bone and cartilage, the cartilage is living and does fine. But the bone itself takes time to incorporate. And if you overload it early, the bone will fail. So we're looking at ways through orthobiologics, for example, to say, hey, can we get that bone to integrate more reliably, more predictably, in a more expeditious way, so that we can, instead of waiting for our athletes to go back at 6 to 8 months, maybe we can do it at 4 months. If I use an autograft, if I take it from you and your body moves from one place to another, that's healed effectively like a fracture in 8 weeks. But if I use donor bone, it could be 6 to 8 months. So every technology has its own challenges in terms of biologic healing. And what you've implied is that the rehab is incredibly important. I will tell you that surgery or treatment in general without understanding of rehab principles and how it affects biology is basically, you'd be missing 2/3 of the equation if we didn't think about that half.
Yeah. No, so you mentioned again, marrow-derived stem cells, MSCs, for various therapeutic applications. And Dimitri Tsoukas, who's logged on from Greece, asked the question about comparing adipose-derived versus bone marrow-derived mesenchymal stem cells. What are your thoughts on that difference?
Some would argue that an MSC is an MSC. And the challenge is that I would say that at least in the management of osteoarthritis, and this speaks back to one of my initial comments about evidence-based medicine, I can find you a little bit of data that's pretty good, that's maybe level 2, for example, that shows that adipose-derived, if there really are MSCs that are active there, and that's the other challenge we have, versus bone marrow concentrate, that the local milieu, the change there might modify symptoms more equally effective, but one study might show better or worse for the other. So we're not ready to say, based upon what we know and think we understand, that one is superior to the other. So unfortunately, a lot of this has been driven, well, I should say fortunately, a lot of it's been driven by economics and efficiencies. And there are technical aspects for each of these procedures. And at this juncture, I think it's important to understand that most of what we're doing is modifying the biologic environment, not necessarily regenerating, but taking advantage of the host's opportunity to either heal. So for example, with rotator cuff repairs, there's some data that shows bone marrow concentrate might, at the time of surgery as an adjunct, might reduce the re-tear rates when evaluated by MRI at 1 year. there's actually a very similar study with adipose tissue that showed similar results with MRI evaluation. Does it help regenerate the enthesis, the place where the tendon inserts in the bone? We don't know with certainty. But we haven't done enough to be able to determine the differences. And as I said, some will argue that an MSC is an MSC independent of the source. We just don't know. And what's driving decision-making at this point is not necessarily evidence-based medicine. We certainly know we're not hurting people in any meaningful way, but we just don't know if one relative to the other is reliably helping someone in all of the ways that we're using these things until further notice, if you will.
That's thank you. We've touched on a wide array of problems, approaches, and I wonder, Brian, when young orthopedic surgeons who have an interest in academic medicine come to you for your counsel about in what investigational area might they take off in? What should they be looking at? How do you counsel them? What advice do you give them about what areas for them to go into?
Well, as we were sort of alluding to, this is just a small box in orthopedics that we're talking about in musculoskeletal medicine. It's not just orthopedics, but it's biochemistry, it's regenerative medicine, it's physics. It embodies every area of science. And I would say to them that the first thing is, find something that you think you love, because and surround yourself with people better than you. And every year we take between 4 in our own little research team. We take between 4 and 6 young people. They're college age or medical school, and some of them are in residency, and they come from everywhere. And they're some of the most motivated, intelligent people I've ever had the opportunity to work with. And it's actually what keeps me going. If all I did was see patients and do surgery, I think it would probably get pretty mundane. The fact that we can have that interplay between surgery, clinical problems, and then take it to the lab, like I talked about, that translational concept, and then work with young people, is the best aspect. It's the blessing we have in our careers. And I know you share the same feelings. As far as young people, what they can look at, I think there is really no shortage of work that needs to be done here. The funding is okay. It's not great. And understand that most of us will depend upon extramural funding and so forth. But this area of orthoregeneration has such an intense level of interest from various stakeholders that I think for the time being, it's fundable work. It's work that's really relevant to what's going through the FDA. And it's work that biotechnology, startup companies, emerging technologies, device companies, and so forth, all have a really high level of interest because the burden of disease is so enormous and the impact on our economy is so enormous. So if you choose big problems, for example, osteoarthritis, looking for big solutions, there's never a day that there's going to be nothing to do. That much I can say.
So a question coming from Dr. Freitas is also logged on. Goes back to cartilage regeneration, and of the array of approaches, cell-based or non-cell-based, that are being investigated, what do you think is the most promising of those that are out there right now toward cartilage regeneration?
I struggle with, I guess the answer is that people have to understand there's not going to be one solution that will solve all of our problems, because patients don't present with that kind of homogeneity. So I've been very impressed with new technologies that are cell-based that have evolved over time. If you look at the only cell-based technology available in the United States, it basically involves biopsy, and it first involved just injecting a liquid of cartilage in essentially a culture medium or buffer beneath a flap of periosteum, the covering of the bone. It evolved then to sort of off-label usage of soaking that into a collagen membrane. Now it involves culturing on a collagen membrane. There's emerging technology that looks to be as good or better to what we currently have in the area of cell-based technology, that is very predictable in terms of delivering a good outcome when it comes to sort of surface-based lesions where you have relatively healthy bone. The flip side is that we have patients with osteoarthritis and emerging technologies that can treat their problems. And a patient who presents with osteoarthritis is really different than a patient who presents with a localized cartilage defect. The challenge is, or the good news is, patients who present with osteoarthritis may be more age appropriate for metal and plastic. And that might be the right answer. But if we had transitional solutions that maybe are not even directly cell-based, but for example, scaffold-based, that can harness the body's ability to heal and or just share load. Load-sharing solutions that are synthetic-based, for example, can provide adequate outcomes in terms of pain relief and functional return, and we don't always have to look towards cells. Whatever the solution is going to be, it's going to have to be cost-effective. Cost is going to be an ongoing issue. It's going to have to be efficiently delivered with a very low complication rate. It doesn't have to have a perfect outcome, and it should be revisable if it fails without burning bridges downstream. So I think some of the next generation cell-based technologies are particularly exciting. The next generation scaffold-based technologies in the absence of exogenous cells are also really exciting to me. And honestly, our focus on disease prevention has to continue. If we can take patients who are otherwise known or identified as people who might or could progress, for example, after an ACL tear, that are likely to develop osteoarthritis downstream. If you and I and these young people that are coming through who want to study, important diseases can figure out preventative strategies that modify disease, we can have a whole different narrative, 5 years from now. So those are very exciting areas, as well as actually deferring or delaying or preventing post-traumatic arthritis from developing from known insults. Also really exciting areas of research.
Yeah, yes, they are. Brian, in my last question, you're coming at you're in the last of your 3-year period as president of the On Foundation. I'm wondering, in what areas do you think the On Foundation can have its greatest impacts?
The On Foundation is a independent organization that has had reliable access to funding for research, education, and collaboration. And they've done an amazing job in the initial 3 years under the supervision of Kay Horsch, and I think they deserve a call out. This is an independent organization that's the equivalent in the United States to a non-for-profit, but funding from a family-owned business, Geislich. And they're dedicated to research, education, and this type of collaboration. And I think that some of our initiatives need to continue to find ways to help further innovation with our young investigators. I remember my first young investigator grant. It was a $25,000 grant that led to a basic science study in looking at the effects of heat on cartilage. And you sort of forget over time, nearly 25 years later, because we're looking at big grants, 500,000, $1 million, multi-year grants and so forth. But that $25,000 then was more meaningful to me than any large grant that I get today, because it just helped me recognize that people maybe cared about what we were thinking about, had the faith that we could do something with it and not let it squander, and that we delivered a publication that was meaningful, that served as a nidus for larger funding through the NIH. To me, providing opportunities in these grant sizes, if you will, to further provide opportunities for our young investigators who have the time and the energy and the intellect to do this is an area that I would like to see the On Foundation continue with. And then the final area is just becoming a true resource that's independent, unbiased, and authentic for people interested in the area of orthoregeneration and orthobiologics.
Very good. Thank you very much. Thank you. So we very much appreciate it. I always come away having learned several things from any conversation with you, and we very much appreciate it. And Kai, I see you're back on. I think we're coming to the end of this interview period.
Yeah. Thank you so much to both of you for taking the time and for that really stimulating discussion. I've also learned a lot, and I got even more motivated to drive the foundation in the direction that Brian just mentioned. Yeah. And I'm more than happy that we can build on you for the years to come to achieve what we are hoping for. And yeah, thank you so much.
It's been a privilege to be involved, and I look forward to the next 3 years. And Myron, that was your questions were just fantastic, and I hope the audience learned, or at least came up with another 50 questions that need to be answered. So thank you, and I wish everyone and their families safety and health in the near term.
Thank you. Thank you.
Thank you very much. And to everybody out there, this interview is recorded, and it can also be found on on our platform beginning of next week. And we will add additional information like links to the CVs of these two giants in orthoregeneration. So,
thank you.
Thank you. Thank you.
Thank you and goodbye.
Stay well. Stay well, everyone.
Bye-bye now.
Bye-bye. Bye-bye.